Good day, everybody, and welcome to today's webinar on image-guided lung protection, the concept and clinical application examples, which will be presented by Eckhard Teschner, who is our product manager from Dräger, Germany.
Okay, so welcome to this webinar. It is about, and let me check. The title of today's webinar is introducing the concept of image-guided lung protection. And it's mainly about the different type of clinical information provided by EIT that we can utilize for the therapy of our intensive care patients. Before I start, I'd like to introduce myself a little bit more. So I'm just very importantly, I'm not a medical doctor. I have a biomedical engineering background, but I also have worked in emergency care and also in the intensive care environment. And I'm the senior product manager of Dräger and have steered the project for developing electrical impedance tomography technology in a close collaboration with the University Hospital of Göttingen, Germany. And in my time being a product manager, I've participated in very many EIT measurements on different patient populations and monitoring a large number of various therapeutic interventions. And we are gathering more and more information also in collaborations with many international research sites with the leading researchers in lung protective ventilation and respiratory therapy in general. Since 2011, where we have launched our initial EIT device, which is a PulmoVista 500, we are continuously improving based on the feedback we get from our collaborations. We are continuously improving the user interface and also the clinical information that we provide. Okay. That much for the beginning. I'd like to start this webinar with recording some basics for those of you who have never heard about electrical impedance tomography. So just getting close to the principle, and I will turn on the laser pointer so that you can follow my presentation more easily. So in order to measure electrical impedance tomography, you have to attach a silicone electrode belt onto the chest of your patients. Typically, we're lifting the patients up a little bit into a rather sitting position, and then we attach the belt starting in the mid position, put it into the neck position, and then we slightly lift the patient in the bed to position the belt in the location that it's located at intercostal space 5. More or less. Importantly, in females, the belt should be attached rather on the breast of the patient rather than under the breast. And then this electrode belt contains 16 electrodes, and we use one electrode pair to inject a little alternating current into one electrode pair, while we are measuring the resulting voltages at the remaining electrode pairs. And with a increase of air content in the chest during the inspiratory phase, we will see that the transthoracic impedance will also increase. And there's a more or less linear relationship between the impedance changes and the volume changes in the chest. So we are using one electrode pair to inject a small alternating current, and then we are measuring at the remaining voltages, the remaining electrodes. We do the voltage measurements, and that lets us determine the intrathoracic impedance. And as air moves in and out of the chest, we reconstruct the dynamic images. And we can generate up to 50 images per second. So we are talking about the technology with extremely high temporal resolution, where the spatial resolution is somehow limited. And this information, the raw signals from the voltage measurements at the electrode pairs, let us allow to display and reconstruct cross-sectional images, waveforms, and parameters. And we can also, as we can use it continuously, we can also present trended data. When we connect the pressure pod, which is a means to collect airway pressure, esophageal pressure, and gastric pressure, we can also use the PulmoVista to display those pressure information with the same device and combine the ERT measurements with esophageal and transpulmonary pressure measurements. So, collecting the voltages at the body surface, how can we generate the local spatial information out of those voltage measurements? That's something I'd like to explain in the start. So as I mentioned, we inject the electrodes, we inject the currents at one electrode pair, and then we are generating electromagnetic field and the distribution of the potentials around the chest, and we are then measuring sequentially the voltages that result and depend on the air content around the chest. After we have injected those current at the first electrode pair, then we quickly swap to the next one. We do the voltage measurements again, and so we are quickly turning around the entire chest, which gives us, with one complete rotation of the current injection, gives us 208 voltage measurements. And those voltage measurements are used to reconstruct the image. So, importantly, we are not measuring and assessing the absolute impedance values, but we are looking on relative impedance changes due to the inspiratory phase and also expiratory phase. So let's say if we have the cross section, we define all pixel values at 0 at the end of expiration. So that is our baseline, as we call it. And then starting from the baseline during the inspiratory phase, you will see that in some regions, the air content will increase. And those are typically those regions where the lung tissue is located, which is contributing to the inspiratory phase and the change in the tidal volumes. And in those areas, we see an area of increased impedance that results in an increase of the voltages that are measured behind this area of increased impedance, if we take it from the perspective of the current injection. So, and depending on the location where we inject the current, you will see that other electrode pairs will detect the increased voltage measurements depending on where you inject the current. So that provides us actually the spatial information in the cross section inside the body. And if we superimpose the voltage profiles above each other, then you can see how stepwise such a regional information is generated. And by the way, this kind of reconstruction algorithm is pretty similar to what we do in the CT scan, even though there are some fundamental differences between these technologies. So let's start with a CT scan. It's important to understand that a CT scan shows the air content of the lungs and not the ventilation. So it's showing air content. But the cross-sectional projection is very much comparable with what we do in the EIT. However, we don't see in the CT scan the changes of air content due to ventilation. Yeah. So the EIT, the CT scan shows you the end-expiratory lung volume, and the EIT will show you dynamically how the air moves in and out of the lungs, and it's all referenced to the end-expiratory level. The blue color in the images in the EIT image means that there's a sufficient ventilation taking place. The white color means there's a maximum of ventilation taking place, but we are not getting any information of the absolute impedance or volume changes that we see because we auto-scale our images, which means no matter how high the actual tidal volume of a patient is, we will always see this kind of color scheme with some white color at the maximum ventilation, blue color with a mean ventilation, and black area mean there are areas that are not ventilated at the end of inspiration. talking about the cross-section. So the projection is the same. So we are basically looking through the feet into the lying patient, which means the left lung is represented on the right side of the image here. But while the one cross-section, one slice of a CT scan only represents 2 millimeters or at the most 10 millimeters, with the EIT image, we are capturing a large slice of the lung that in adult patients probably represents about 1/3 of the entire lung. And that also explains why we have such a high correlation between, for example, the volume waveform of the ventilator and the impedance waveform that we see in our EIT device and the PulmoVista. As I also mentioned, the spatial resolution of our EIT images are relatively small as compared to a CT scan. On the other hand, we will have a high temporal resolution because we are capturing up to 50 images per second. So now with the EIT, we can also take end-inspiratory snapshots. And then if you take those snapshots, they're called the so-called tidal image. And they then can be subdivided, for example, in ventral, mid-ventral, mid-dorsal, and dorsal parts. And so we can distinguish the ventilation in the non-dependent lung and in the dependent lung. Of course, in your patients, you won't see images typically with so nicely, evenly distributed ventilation, but you rather see images where you have, for example, dorsal collapse or pleural effusion. And so initially, the direct information that we provided was the monitoring of regional lung volume or regional tidal volume. But right now, we are getting more and more information that is more specific for specific lung conditions. So we are able to detect conditions such as pleural effusion, overdistension, cyclic opening and closing, or a pneumothorax. And that is something that I would like to quickly introduce in order to understand the capabilities of our device much better. First of all, the direct information and how we can quantify the regional distribution of ventilation is with the concept of the so-called regions of interest. So we can subdivide our regions of interest into quadrants. And then when doing that and having a subject with a homogeneous ventilation distribution, we can expect that each of the quadrants will probably receive between 20 or 30% of the total ventilation. And the total ventilation of all 4 quadrants is always summed up to 100%. If we subdivide our tidal images into layers in order to distinguish between dependent and non-dependent parts of the lung, then we typically should expect around 10% in the ventral part, 10% in the dorsal part, and the rest of the ventilation is typically more or less evenly distributed in the central part of the chest. I should mention that, of course, ventilation distribution depends a little bit, or maybe I should say depends strongly on the position of the belt. So we should make sure that we are not putting the belt into the mediastinal region, but slightly above it. That corresponds to intercostal space 5. So that is a recommended position for the belt in order to avoid that, depending on the position of the mediastinum, we have a significant impact on the distribution of ventilation. The second information that we also can present with EIT is changes of the end-expiratory lung volume that are represented by the changes of end-expiratory lung impedance. So for example, the easiest way to change the lung volume in patients is to change PEEP settings. When we increase the PEEP setting, we are increasing the force that keeps more air inside the lung, and that will always result in an increase of the end-expiratory lung impedance and the lung volume. And that is something that we also can detect and quantify non-invasively, even on a regional basis, with the use of electrical impedance tomography. The second condition that we can also take a look on actually requires a little diagnostic maneuver. It doesn't need to be necessarily a complete PEEP trial, but at least we have to compare two PEEP steps with each other. And in this example, where we can detect overdistension, this is a classical pattern when you had a ventilation distribution at a lower PEEP level, which was including the gray area. So at the lower PEEP level, this area was actually blue. And now if you increase a PEEP and you see a reduction in the ventral part where the compliance has been lost or the ventilation has been lost, then this is already an indication of overdistension. We also have the means to calculate compliance changes. So this is basically the direct volume change. And here we can also compensate for possibly changed driving pressures. So here in this orange images, we can also calculate the regional compliance of the respiratory system. And so if we have this drop of compliance or this drop of volume at a higher PEEP level, and typically occurring in the ventral part, that is already an indicator for overdistension. Vice versa, we can also say if we have a certain ventilation distribution at a lower PEEP level and at a higher PEEP level, we could manage to get dorsal ventilation, which is now in the lower PEEP level in gray. That means that would be an indication of alveolar collapse at lower PEEP levels, which could be ventilated at higher PEEP levels. You can either, again, display this with a tidal volume information, where you have no dorsal ventilation taking place here, or you could also compare and calculate the drop of compliance towards lower PEEP levels. And when this goes hand in hand with an absolute information on the tidal volumes, then this is an indicator of lung collapse. And this concept with a change in lung compliance, depending on the PEEP settings, has been already described by a group from Brazil in 2009 already. And this publication, the title of it was Bedside Estimation of Recruitable Alveolar Collapse and Hyperdistension. And the concept is that you have to apply a PEEP trial with at least 3 PEEP steps, in the best case at least 5. And then you're looking at each pixel and determining the maximum compliance that you have found in the PEEP trial. And typically what we see in all patients is that the pixels in the non-dependent lung, they're requiring a lower PEEP level to reach the maximum compliance, like in this example, while dependent pixels, the pixel B here, that has a maximum compliance at significantly higher PEEP levels. And that is a pattern that we always see in our patients, no matter if it's postoperative patients or ARDS patients. Of course, the changes between those 2 pixels in terms of the PEEP settings are much higher the more weight the lung has and the more lung disease the lung is exposed to. And then the rest is just, so for each of the pixels, we are always getting a PEEP level with a maximum compliance if the PEEP trial has been conducted properly. And then the rest of the interpretation, which means if the compliance decreases towards lower PEEP levels, this is interpreted as collapse. And in contrast, when the compliance decreases towards the higher PEEP levels, then it is lung loss of compliance towards higher PEEP levels and interpreted as hyperdistension. So that is a concept, and the only limitation is that this actually requires to conduct the PEEP trial. Then the next information that we have also implemented into our software is the analysis of the regional ventilation delay, because there was also a paper from 2010 which has described this approach to be suitable of detecting cycling opening and closing in patients with a dorsal collapse. So the typical pattern of cycling opening closing would be that it's occurring in a very small, relatively small transition phase between collapsed lung tissue, represented here in the gray color, and normally ventilated lung areas. And then when you look on the affected pixels, you will see a late opening during the inspiratory phase, because first the opening pressure has to be reached in those affected lung regions. And you see that at the end of inspiration, we have no delay anymore. However, we also often see an early closing of the affected lung parts. And I should also mention that these effects are also very much dependent on the PEEP settings, which means if you go higher with a PEEP, you won't see this delay anymore, and that area will be fully opened without a regional ventilation delay. If you decrease the PEEP of such a condition, you probably will achieve a lung region which will remain collapsed during the entire respiratory circle. Okay. And then we have introduced the diagnostic view in our device because we wanted to have a view that can be used user independently, and that is capable of, for example, during a PEEP trial, but also during other therapeutic interventions to detect the most harmful lung conditions, which is cycling opening, closing, overdistension, and collapse. So let me quickly introduce this view. So first of all, we have an impedance waveform like in our other views, where we can track and trend the impedance waveform over a time up to 2 hours. And then we have implemented an algorithm which automatically detects PEEP maneuvers and automatically assigns the so-called sections which allow to assess any kind of PEEP level that has been applied during the PEEP trial. And for each of those sections, we are getting the resulting tidal images. And then in this example, where the PEEP trial was conducted from the highest PEEP of 14 in steps of 2 down to a PEEP of 6, we basically see that for a PEEP level of 14 and 12, the lung remained fully ventilated. At the PEEP level of 10, we started to see some cycling opening and closing. And if you reduce the PEEP level even further, you see that the affected lung region, the yellow part here, will remain completely collapsed. And then with the PEEP level of 6, you see that the dorsal lung has already been completely collapsed. And then this complementary information is provided by this approach from the group of Brazil, the estimation of overdistension, which typically decreases when you go further down with the PEEP levels. But at the same time, however, you see that the dorsal loss of compliance is getting larger and larger the more you decrease the PEEP. And this two effects, opposing effects, that typically result in a opposed signal in the overdistension and the collapse. And this crossing point between these two graphs can be interpreted as the best compromise between overdistension and collapse. And in recent study, this intersection point has been used to set optimal PEEP. So we got a view now where we can monitor and display the most harmful lung conditions in one view, and it's completely independent from the user. Then, after we have introduced the regional ventilation delay parameter, we found a different pattern that is also detected by the regional ventilation delay, and that is a pattern of Pendelluft. So Pendelluft that occurs typically during a high inspiratory drive and spontaneously breathing patients. We rather see large regions in the ventral part, which are affected by the regional ventilation delay. These regions are typically independent from any PEEP settings because it's mainly determined by the respiratory drive of the patient. But of course, those regions of regional ventilation delay will probably disappear after sedating the patients. And so the typical pattern in the waveforms, when you compare the white waveform, which is basically the volume waveform of the ventilator, with the pixel waveform of this marked pixel here, then you see that this is actually a delay of the entire respiratory cycle. So even at the end of inspiration, you see that the local curve is significantly delayed as compared to the average signal of the lungs. And this is a pattern, as I mentioned before, that we only observe during spontaneous breathing. Those effects have already been also studied and described in various clinical studies that have been published. And again, this is another example of a pattern how Pendelluft effects can be displayed and visualized with the EIT or with a regional ventilation delay. Now, that were two examples of characteristic patterns created by the yellow spots in the images. And then at the other side, we can also detect pleural effusion. And to detect pleural effusion, we have to focus on the so-called purple spots or phased opposed signals. Phased opposed signal mean when we see ventilation in the pixel 1, represented by this green waveform here. We tend to see in some lung conditions phase opposed signals, which means whenever you have a maximum in the ventilated area, you get a minimum in the local curve that is displayed in purple color. So it's not a phase delay, but it's rather a phase opposition, and this is actually caused by a technical artifact. However, this technical reconstruction artifact is always generated when well-ventilated lung tissue is located next to areas with fluid, areas where the mediastinum is located, or also a pneumothorax. And that is something that I would like to give you some examples on. But first, in order to confirm that this is information that also results in a characteristic pattern in patients with pleural effusion, I would like to mention the study where this has initially been described. And this was a study where patients with a confirmed pleural effusion, confirmed with ultrasound, were measured with EIT before and after drainage. And there you already can see that you have a statistically significant lower number of purple spots in the patients after drainage. However, compared to the control group, patients with confirmed absence of pleural effusion, the purple spots are still much higher. And they found that the authors of the study found that this characteristic pattern results in an extremely high sensitivity and specificity in patients with pleural effusion compared to the control group. And in PulmoVista 500, we have introduced a function where we can actually highlight those purple areas. And then you can definitely clearly identify which of your patients will have pleural effusion. Right now, we do not have a quantification of those areas, which would be also beneficial, but at least we can directly display these kind of lung conditions. And just to mention why this information is so relevant, so if you should consider to do a lung recruitment maneuver in these kind of patients, you will probably see no success because pleural effusion cannot be compressed or eliminated by a recruitment maneuver. The last example I would like to show you and to illustrate is the detection of a pneumothorax. Pneumothorax is something that has not really been systematically studied, so the most reports on EIT related pneumothorax or pneumothorax detected by EIT, I should say, is single case reports. And Well, there's definitely a characteristic pattern in the way that we have an absence of ventilation in those affected lung regions. That is clear. But then when we enhance the colors, you will also see that you can clearly also see the purple spots, the reconstruction artifacts, because in comparison to the lung tissue, of course, the area with the pneumothorax, which contains pure air, has also a completely different impedance as compared to the lung tissue located next to this spot. So that is also a characteristic pattern that can alert of a pneumothorax. So to conclude, with this kind of information, we can say that EIT probably has a capability of revealing the most common but harmful lung conditions in critical care patients. And I mean, the nice thing about electrical impedance tomography is that it also can provide immediate feedback at the bedside, because it can be used continuously, and because of the trend information that we provide, it can be nicely used to follow any therapeutic intervention. Okay, so what is the relevance of this information when we take a look on, for example, PEEP titration and optimization of PEEP levels? And in that context, I would like to recall some learnings that we had from the ART trial. For those of you who don't know about the ART trial, it was a trial conducted in 2016, published in 2017, including more than 1,000 patients. And the objective was to follow rather the open lung approach, so to make a relatively aggressive recruitment maneuver, and then to do a subsequent PEEP trial in steps of 3, and then to identify the best PEEP. However, I should say in this study, EIT has not been used, but the best PEEP was titrated according to the highest respiratory system compliance. And that was the study group, and the control group just received the low PEEP table of the ARDS network protocol. However, in this study, it was found that the study group resulted in the treatment according to the study protocol, resulted in a higher mortality by 6% after 28 days after randomization. And so there were lots of discussion about this trial, and the question was actually, is PEEP trial, conducting PEEP trials and recruitment maneuvers something that simply increases mortality? And of course, it, as so often, it depends a little bit on the response of the patient to these kind of maneuvers. And what the authors found was that the higher mortality and the observed harm in the ART strategy seemed to be concentrated in those patients with null recruitability. So that is, I think, also a very important finding, which means before doing recruitment maneuvers and PEEP titration, we have to assess lung recruitability in order to identify those patients who might benefit from a PEEP trial and a recruitment maneuver. But as they also stated, without more intensive monitoring, and that it certainly includes EIT, it was hard to point out how to identify the responders and the non-responders in this patient population. So how can lung recruitment be assessed? We had already early publications from the group of Luciano Gattinoni in 2006, where he already pointed out that individual ARDS patients react completely differently to the same maneuver, which in this case was the comparison of pressure applied at 5 centimeters of water and then comparing it to 45 centimeters of water. So in some patients with a lower percentage of potentially recruitable lung, we see almost no differences in the ventilation distribution in those patients. The only effect that we see is that the heart is, or the mediastinum is pretty much compressed. In contrast, in other patients with a high percentage of potentially recruitable lung, you see that the white areas that we had in the CT scan at lower PEEP levels or lower pressure levels were getting much more dark, and so the aerated areas increased significantly at the higher PEEP. So it's certainly worth to look for approaches to individually assess lung recruitability. However, as we all know, CT scan is not always suitable and also not always accessible for that purpose. So how can image-guided assessment and lung recruitability give some information on who of our patients is a responder and a non-responder? First of all, I would recommend to just take a look at the static tidal image that we get presented in EIT. And whenever you should have a patient which has a evenly large ventilated region with dorsal ventilation in the regions of interest of more than 8%, we probably do not see any kind of need to even test lung recruitability, because those images most of the times already tell us clearly that whenever the patient has issues with the gas exchange, it's probably not related to the ventilation distribution if you see these kind of tidal images. However, in other patients, you might see a very asymmetrical shape of the ventilated areas with absence of typically dorsal ventilation here. And that is, of course, a patient where it's worth to take a closer look and maybe to do a little diagnostic maneuver in order to assess lung recruitability. And another example where it makes a lot of sense to test recruitability is when the ventilation distribution is only occurring or mainly occurring in the ventral half of the lung. So in very many cases, especially in postoperative patients, we see that more than 80% of the ventilation is distributed towards the ventral half of the lung. So first part should always be to check for signs of lung collapse or at least absence of dorsal ventilation. And what I also would recommend you to do is to, because remember I presented this examples of patients with pleural effusion, which is indicated by the purple spots. So you should always use initially the button enhance colors in order to check for pleural effusion, which would then be presented in the purple colors. And then I would propose to do a little test maneuver in those patients where you want to assess lung recruitability. And that can be very easily done by just elevating the PEEP moderately, let's say by 5 centimeters of water for a time period of 30 to 60 seconds. And then you can use the function recruitability of the diagnostic view to compare the status before and during this PEEP elevation. And that is for checking for compliance changes. So comparing the compliance win and the compliance loss. And at the same time, you can also go back to the initial level of PEEP setting, and then you can compare also the changes of end-expiratory lung impedance that might have been induced by the increase of PEEP. And now I'd like to just show you 3 different cases and how those data can be interpreted. First of all, we do not have to do any recruitment maneuvers or not even to test lung recruitability when you find the ventilation distribution like in this subject. However, this subject was part of a clinical trial where this temporary increase of the PEEP had been conducted. But as to be expected, because the lung was already fully opened, we only or mainly see a deduction of lung compliance in the ventral part. And so there's not really any kind of benefit that we can see by the elevation of PEEP. So this is a patient which certainly does not require a PEEP titration or a recruitment maneuver. And then, as I mentioned on the slide before, if you determine already, okay, there is a patient that has a ventilation distribution of 10% or even more, then those patients do not have to be considered for conducting a lung recruitment maneuver. And at the same time, I would also not recommend, or I would predict that it's not beneficial to do prone positioning in these kind of patients. When you take a look on the increase of end-expiratory lung volume, I mean, of course, you see an extremely high increase of the lung volume while you have increased the PEEP, but that increase is mainly induced by the elevation of PEEP, which basically keeps more lung volume inside the lungs at the end of expiration. If you go down with the PEEP again, you still see that you have gained a certain amount of lung volume, even though the PEEP level before and after this maneuver was kept stable. However, this effect is probably vanishing away over time. So it's just a temporary effect that is also not so much beneficial because ventilation was already present at the baseline condition. Another example. So this is an example where obviously here's a very asymmetrical shape of the dorsal ventilation distribution. What you also see is absence of ventilation in the dorsal left lung. And so if you do this little test, in this case, the PEEP was only elevated by 4 centimeters of water. You see minor improvements of ventilation. However, you see that elevating the PEEP does not in any case increase the ventilated area that is projected here. So it's also not beneficial for the ventilation distribution because the area that you intend to open remains completely collapsed. There's no gain in dorsal ventilation in none of the lungs. When you take a look on the end-expiratory lung volume, you also see no significant changes when you return back to the baseline condition at this section C. So here the explanation why this also was a non-recruiter is this was another example of pleural effusion in the left dorsal lung, resulting in a very low ventilation distribution in the dorsal layer, in the dorsal region of interest. However, because it was pleural effusion, this lung could not be recruited. Last but not least, I would like to show you a typical example what we often see in postoperative patients. Here the PEEP was increased by 5 centimeters of water, but you see already in the initial but also the following tidal images then that the majority of ventilation is distributed here into the ventral part. And if you see these kind of patterns, and sometimes you even see no ventilation taking place anymore in the dorsal part, then these are the patients where the recruitment maneuver and the subsequent PEEP trial could be extremely beneficial. So in this case, even though we only have seen a moderate elevation of PEEP, you see that you get a significant gain of central or even dorsal ventilation. And if you would have increased the PEEP even further, probably this gain also would have been greater. Here, in this case, we do not see a significant change of the lung volume, but still this information on the regional compliance changes really proposes this patient could be a responder to a recruitment maneuver and the subsequent PEEP trial. As I said, here, this is a typical patient where we have 80% on the ventilation in the ventral half of the lung. Okay, so that is an approach how you can simply, by just temporarily elevating the PEEP a little bit or decreasing the PEEP when the PEEP is already quite high, we can just change the PEEP settings for a short period of time, and then you can interpret the reaction of the lung. The second one If you have identified patients where PEEP titration could be beneficial, then of course you can do this maneuver that I've explained before. And then you can basically see that in some patients, you see no changes during the PEEP titration, even though the PEEP has been changed here from 15 down to 6. And that means in that case that probably this patient had a fully opened lung already at the lowest PEEP level, so there would be no need to further increase the PEEP. So again, this is an example of a non-responder. Another example here is a partly collapsed lung, and in this patient, you can demonstrate that this patient actually requires a higher PEEP. However, probably also due to a pleural effusion, the left dorsal lung could not be opened. But still, in the right lung, the ventilation distribution at the highest PEEP is much more homogeneous as compared to the PEEP level of 6. So this is a patient where PEEP titration is required or certainly beneficial. And another example is this example that I explained before. So whenever you see these kind of patterns that with a decreasing PEEP, you see the growing collapse of the dorsal lung, these are definitely the patients that will significantly benefit from PEEP titration and optimizing the PEEP based on EIT. Just to mention, in this pattern, in this example, we also saw a cycling opening and closing again. Again, the criteria are, we don't see any delay at the end of inspiration, but we see a delay during the inspiratory phase and also early closing during the expiratory phase. And if you check for the PEEP dependency, yes, if you slightly increase the PEEP, the lung will remain open, while when you decrease the PEEP, the lung will completely remain collapsed. So in this case, even though I suggested the crossing point should be used to set PEEP, in this specific case, we should go a little bit higher with the PEEP settings, because a PEEP of 12 keeps the lung completely open, and there are no signs of cycling open and closing in this patient. Okay, but then of course we can ask ourselves, does this approach based on EIT really make a difference in the clinical outcome of our patients? And then I would just like to present you the first outcome studies, which have already demonstrated benefits. So over the last 10 years, there have been many studies in different patient populations, but also partly with different EIT-related parameters to titrate PEEP. We have always seen quite positive effects, but these initial studies have not been designed yet as randomized controlled trials, so no outcome studies. However, they all demonstrated that PEEP titration based on EIT parameters is feasible. Now, the first outcome study that was published in 2021 was the one from, I think from China or Taiwan, I'm not quite sure. And in this study, it was found that in moderate to severe ARDS, the PEEP titration guided with EIT has improved driving pressure. So the required driving pressure was lower. And also there was a positive sign of towards a survival rate in this patient population. The control group in this study that they have used was low inflation or PV loop maneuver, and the PEEP titration based on the information from the PV loop. Another study has found similar results, and in this study, they have controlled. They have had a control group with a low PEEP FR2 table according to the ARDS network protocol. And here in the conclusions, they found that there is a decrease of 6% in mortality in the EIT group. So again, very much promising result, even though they have not been statistically significant. But I mean, this at least provided already promising results that justified to do larger trials on EIT-based PEEP titration. A recent study from 2023 also has investigated the mechanical power during a PEEP trial, and they found that the EIT-based PEEP titration, and it was again done by optimizing the PEEP based on the best compromise between overdistension and collapse. They found that titrating PEEP in their patient population reduced mechanical power in their ARDS patients. Also very promising results. And currently, I should say that the most promising study might be the one that is currently conducted in China, where the study protocol just has been published recently, however, not the results yet. And in this study, again, as a control group, the low FR2 PEEP table will be used. They will apply a recruitment maneuver in order to make the study group and the control group more comparable. And this is actually a study where close to 400 patients will be included and recruited. And so we are very curious to see the results. Again, the PEEP optimization based on EIT will again be done based on this crossing point in the tracings of the overdistension and collapse. Okay, so to conclude, EIT is currently a suitable tool for assessing the response to therapy. So it's capable of predicting lung recruitability during the monitoring recruitment maneuvers itself, and also PEEP titration, but it can also equally be used during the proning phase or during weaning. There are many other applications during therapeutic interventions where this type of regional ventilation monitoring might be useful. And so it can very nicely be used to maintain lung protective ventilation by avoiding the alveolar collapse, alveolar overdistension, or cycling opening and closing. Okay, so that was it for today. I thank you very much for your attention and for taking the time to listen to this webinar. And well, there's more to come, and thank you.
Thank you very much, Echo, for a fantastic presentation once again. To all our attendees, I don't see any questions at the moment. So if you do have questions, you are welcome to email us, and we can then forward those questions on to Echo, and he can then provide you with the responses. So at this time, there are no questions. So with that, then we would like to end off this webinar for today. Thank you once again for attending and for staying online. And take care and have a good day. Goodbye.